Bismillah, alhamdulillah, wassalatu wassalam ala rasulillah. We are happy today to start breast modality. Next modality, breast MRI introduction and technique, presented by Dr. Rabab Muhammad, consultant radiologist. We are happy today to start the MRI breast. Welcome, Dr. Rabab. Yeah, you want to start now?
Thank you, Zuhair. بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين سيدنا وحبيبنا ونبينا وقدوتنا محمد بن عبد الله وعلى آله وصحبه أجمعين ونتوجه إليك يا رب العالمين بجاه محمد موفقين. Greetings all. Today I am presenting a breast MRI introductory lecture, mainly including technique. You are all welcome. If you have questions, comments, or suggestions, please you can write them down in the chat box, or you can open your mic at the end of the session and speak directly. Stuck. Bismillah ar-Rahman ar-Rahim. As you know, the three main modalities working in breast evaluation are the mainstay, mammogram, and the second chair in the orchestra of the diagnostic breast imaging, high resolution ultrasound, and during the past decade, multimodality breast imaging approach, magnetic resonance imaging has come to light as a valuable tool in breast imaging. MRI detects cancer which are occult on mammography and ultrasound. Okay. Our goal for the breast imaging, for breast MRI lecture series is that by the end of the sessions, we can understand what is breast MRI, how to do breast MRI, when to do breast MRI, how to read breast MRI, how a normal breast looks on MRI, pitfalls of MRI, breast MRI advances technique, breast MRI implant evaluation, breast MRI biopsy, and breast MRI case example. And today we are going to discuss the first two. Okay. What is the MRI sequence and what does it show?
T2 axial.
T2 FASA.
Excellent, well done. Demonstrate what?
Multiple cysts.
Excellent, well done. Okay. What is breast MRI? And breast MRI is a magnetic resonance imaging. It's also called magnetic resonance mammography, MRM. It is a non-invasive technique for imaging the breast. As opposed to mammography and ultrasound, MRI is a functional technique. Okay. Can you see any abnormality in this image? Can you detect there is a cancer in this image? Can you tell where is the cancer? In which site?
It is in the left side posterior.
Where is, which one? This side, here or here? Which side?
At the left.
This area? This or this? Huh?
I think
Mm-hmm.
I can see
Here?
something far posterior.
This,
here at the
this
end
or
of the
this one? Which one? This one, you are talking about this or about this?
I'm talking about this end.
Here or here? Here?
Here, yes.
Uh-huh. Okay, any other suggestion?
In the right side.
The
In
right
the
breast.
middle right side.
This one?
No. In the middle.
Here?
Yes, this one.
Okay, this is the left breast. This is the left breast. Because the patient prone. This is the left and this is the right. Okay? So you are talking about the left. So here, suggest
Yes.
the left breast. Okay. But if you look here, it is written, there is invasive lobular carcinoma. There is invasive lobular carcinoma. Where? Can you see it? Can you see the invasive lobular carcinoma? You cannot see. It is difficult. Now it is, you can see it well. Yes?
Yes.
It
In
does
the right.
appear. Okay, in the right breast.
Introduction.
Yes. But before contrast, it was really difficult to tell. But the only things here you can see, subtle skin thickening, and this extends to the nipple areolar complex. But it's really difficult because the parenchyma itself, it is complex. So the first image, there is an indication of unusual growth in the right breast, but nothing dramatically different from the other breast. However, lesion detection is primarily performed by using contrast. Okay. After contrast, subtraction image speculated mass with this linear enhancement extending into the nipple. Okay. So contrast enhancement breast MRI was first performed in the late 1980s. And breast cancer showed significant enhancement. Most tumors enhancement threshold within the first 5 minutes. Not only malignant lesions enhancing, and there is overlap between the different tissue enhancement. Breast was the first organ in which invasive tumor neovascularity was highlighted through application of dynamic contrast MRI. Which have extreme high sensitivity. More than 25 years of technical development and dedicated breast coils defining characteristics to distinguish benign from malignant process lead to contrast enhanced MRI has been established as the most sensitive method of breast cancer detection. So in recent years, dynamic contrast enhancement, breast MRI, has become increasingly useful in the detection and diagnosis of breast cancer, and has altered the management of women with breast cancer. And breast MRI is an indispensable modality in conjunction with mammography and ultrasound, considered to be strong tool of breast imaging, and become an essential examination for breast pathology, allow excellent discrimination between benign and malignant, and screening breast MRI has shown higher sensitivity rates in the detection of breast cancer compared to mammography and ultrasound, or both combination in asymptomatic high-risk women. If you look here, you can see here these two small masses, and this is screening mammography in the inframammary fold. This is a sagittal post-contrast MRI. if you see here, these 1 and 2 are corresponding to what we have seen on mammography. Okay, can be visualized. And furthermore, a third lesions, excuse me, there is someone at the door. Sorry for interruption. Okay, what we have said, there is a third lesion detected on MRI was not seen on mammography here, posterior superiorly. Not only that, but here MRI also demonstrate a suspicious intramammary lymph node that demonstrated as intense hypermetabolic activity in a PET scan not shown here. Okay. Breast MRI has the highest sensitivity among the breast imaging in the current clinical practice, ranging from 71 to 100%. And sensitivity of DCIS is 40 and 100%, ranging between low and high grades, and can detect some DCIS missed on mammography. Regarding the specificity, it is a little bit lower, ranging from 81 to 98, depending on technique and diagnostic criteria. If we look here for this is a high-risk patients, okay? Her screening MRI demonstrate this suspicious focal area of enhancement with corresponding negative mammosonography, MRI-guided needle localization, surgical excision reveal the radial scar and fibrocystic changes. So, indicate the specificity is a little bit lower, and therefore, breast MRI should not be interpreted alone without reviewing mammogram and ultrasound, and that is also not useful as a general tool for screening. MRI does not replace conventional imaging or biopsy. What does it mean? So we should not jump directly and do breast MRI without doing mammography and ultrasound, and mammography or ultrasound or both. Then we have to proceed for MRI. MRI is a highly specialized diagnostic technique that complement or adjunct the clinical assessment and the conventional imaging, as well as the FNA or the histological diagnosis. So it adjuncts the triple diagnosis, the non-triple diagnosis, and should not perform without conventional imaging, as we mentioned earlier. Sorry for repetition. I don't know why it comes here again. It comes. Breast MRI is the best performed in a multidisciplinary setting with access to additional breast imaging. Okay, how to do a breast MRI? Okay, First of all, we need a magnetic field strength, which is supposed to be high field strength. It is really essential for achieving selective fat saturation, offer high signal to noise ratio, and allow higher spatial resolution, which improve both sensitivity and specificity. So it is best practice to use a field strength of at least 1.5 Tesla to acquire image at a sufficiently high spatial resolution. And we need a magnetic field uniformity and homogeneous across the field of view, including both breasts. The non-uniformity can result in artifact leading to non-uniformity of fat saturation. Can you see here, this breast is more black than the other breast. The second things, we need a radiofrequency coil. So to achieve or to obtain an image of diagnostic quality, we have to utilize a dedicated breast coil. We cannot do breast MRI on a body coil, for example. We have to have a dedicated breast coil. The choice of proper dedicated breast coil is also critical for obtaining a high quality study. There are unilateral and bilateral coils as seen here. This is a unilateral and these are the bilateral one, okay? But currently, standard bilateral breast coil are almost always used. The ideal features of a dedicated breast coils are patient comfort and easy position, adequate coverage of breast and chest wall. Some of the coils might not accommodate huge breast, large breast. So we need an adequate coverage for bilateral or for bilateral breast. The coil has to have high signal to noise ratio, to have easy access to breast for interventional procedures like seen here in this, because MRI aims to depict lesions that are occult with other modalities, okay? Imaging facilities must have tools to approach that lesions, okay? For localization, for biopsy, or for localization to be surgically removed. And I'm not going to talk about all these details. Unilateral versus bilateral. To have a bilateral breast imaging, it will give us a full simultaneous coverage of bilateral breast, which is really needed for comparison, and it facilitates detection of physiological glandular uptake or background parenchymal enhancement as seen in these examples, okay? As well as it allow us to detect any asymmetry in enhancement as in these examples. So bilaterality, with bilaterality, less likely to miss DCIS. Here I have, this is my patients. And if you see here, there is extensive abnormal enhancement in the left breast compared to the right. And this is a sagittal view of the same patient in a case of invasive ductal carcinoma. So it facilitates detections of abnormal diffuse or focal enhancement. It's also provide a better overview of both breasts, facilitating detection of bilateral breast lesions, and this example of bilateral metastatic breast, and if we can see here, the new phenomena of Sudanese ladies, the cross midline lymphangiectatic spread, bilaterality, allowing us to see the extent of the disease from the affected left breast across the midline to involve the contralateral right breast. Here you can see the edema extending, this is a T2, and the edema extending across the midline, and here the enhancement also, abnormal enhancement with enhancing, multiple enhancing lesion in the midline and in the medial aspect of the contralateral breast. The third thing is the patient positioning. The patient for breast MRI lies in prone position with the breast hanging free in the recess of the coil, as you have seen here. Okay, and you can see the patient lies prone, and this design giving access to intervention procedures when things. It's also ensuring no folds and allows the breast to spread inside the coils, which facilitate detection of abnormalities. Pulling the breast away from the chest wall, it will minimize its movement during respiration. So it will prevent motion artifacts induced by respiration. Displace the breast away from the heart, it will limit pulsation artifacts. It's also allow some compression of the breast within the coil in these hanging positions, and it will correct positions, it will give a correct positions for, and we have to put the nipple in a correct position within the coil. It is essential to use a foam wedges for a small breast, you see, to fill the space. This will limit the movement artifacts, okay, that can alter the subtraction sequences, and we'll see it later. This, if the patient, if there is a poor coil positioning, okay, for the breast, here there is folding. Can you see? There is folding of the breast. It is not well positioned inside the fold. And if it is not well positioned, the patient will not be comfort, and the patient might move during the study or during the examinations. And this can result, this motion artifact can result in a fuzzy lines, can give also misregistration artifact in subtraction images and showing an abnormal enhancement, which is not true, not seen in native post-contrast images. And here also can result in aliasing artifacts. And if you look here, you can see there is enhancing lesions or enhancing structures seen in the left breast. This is in a 3D image. This is malpositioned nipple, okay? Give a false impression of a lesion, not a true lesions. So well positioning of the patient is essential. The field of view should cover the entire bilateral breast. The whole breast should be included within the coil, okay, including the axillary tail and the inframammary fold. As you have seen in the first examples, the lesion was seen at inframammary fold, so it has to be included, and the axilla should not be excluded from the field of view because of metastatic adenopathy, and sometimes even rarely we might find a primary cancer in the axilla. Here you can see this fat sad image T2, and non-fat SAT. These are the lymph node, normal lymph node in bilateral axilla, and this is T2 demonstrates metastatic enlarged lymph nodes. Okay. Patient preparation. There is no special preparation for breast MRI. Just a small dose of relaxant might be needed for those who are claustrophobic. Okay, and we need to have breast history form, which is fundamental for interpretations, including the hormonal status. We need to know if the patient menopause or premenopause. If she is premenopausal, the day of her menstrual cycle is important, if she's pregnant or not, if she is breastfed, if the breastfeeding stop or still she's lactating, if she's on exogenous hormones like hormonal replacement therapy in postmenopausal women, which we need to stop it and repeat the MRI or do the MRI. If we know it, we have to stop and do the MRI after 4 to 6 weeks after the stoppage of the hormonal therapy. And if the patient premenopausal, we have to ensure to perform the MRI in the 2nd week due to the physiological changes. And at this week, okay, we can achieve the least enhancement. We avoid the secretory phase when there is a significant increase enhancement that can give abnormal false impression, I mean. Also, we need to know about the family history and the personal history. If the patient has personal history of breast cancer, she has lymph node dissection, the special date of surgery, date of end of radiotherapy, if she received radiotherapy, chemotherapy, or hormonal treatment. We need to know all these details because it affects the interpretations of the MRI. And it is good to do the breast MRI before biopsy so as not to give false impression due to post-interventional changes. If we see here, the MRI is giving intense background parenchymal enhancement, okay, in this premenopausal woman. So we need to select to do the MRI is the 2nd week to avoid this intense enhancement. And look, this intense enhancement, and the patient already high risk, he has a personal history. So this intense enhancement, we call it MRI dense breast, and it lower MRI sensitivity. Compare it with this background, mild background enhancement, and this is abnormal enhancement. Here is obviously visualized, but if you can apply it here in this background, definitely you cannot discriminate such an abnormal enhancement from the background enhancement. But if you have been faced by this type of enhancement, intense enhancement, we can do the subtraction technique to reduce or to eliminate this intense enhancement and can help us or facilitate to visualize any underlying abnormal enhancement. Here we can see breast MRI, example of breast MRI patient questionnaires. Okay, what are the contraindications for breast MRI? Are general contraindications like the patient unable to lie prone, to be positioned within the coil, or if she has large breast cannot be accommodated within the coil, large body habitus cannot fit into the bore of the magnet. If the patient pregnant, relative contraindications, contrast study, and usual contraindication to MRI, like those who have vascular clips, occult metal, or clips in brain, like all these general contraindication. And we have to consider the patient issues, including cost. Okay. What are the imaging protocols? Scan time 30 to 60 minutes. Many techniques widely used depending on hardware and software personal preference. And the main breast cancer protocols, same for diagnostic and screening, which basically gadolinium enhanced imaging. And we have a different protocol for implant. Okay, so the IV, the imaging protocol components of multi-parametric breast MRI, including many protocols or many components, each with advantages and disadvantages. As we mentioned earlier, the basic is the multi-phase high-resolution T1 pre and post contrast T1 pre and post contrast dynamic study, and T2 sequence. Then can include diffusion weighted images, T1 non-fat sat sequence, as we have mentioned earlier, unilateral or bilateral, no more important since all MRI nowadays are bilateral breast imaging, 2-dimensional and 3-dimensional images, scanning in sagittal, axial, or coronal planes with or without compressions, gradient or spin echo, fat suppression or non-fat sat, then post-processing, including subtraction technique, multiplanar reconstructions, maximum intensity and time intensity care. So we'll go through all of these, don't worry. Okay, here we can see a high resolution technique. We need high resolution techniques. So with the high resolution, we can see detailed images, detailed abnormalities. Okay, here we can see this segmental clump enhancement in a case of DCIS in this MIB image, and here you can see the intramammary lymph node is well visualized. So it is important to have a high resolution technique. Scanning in sagittal and coronal is really helpful. If you look for this lesion here it seems to be a bilobe. It's different. Here is irregular. It is at the end, it is irregular, but even the extent of the lesions is difference between the axial and sagittal view. So it is important to visualize multiple planes. And if you look for this image here, you can see an abnormal enhancement. It's able to answer questions about the involvement of the chest wall and the pectoralis muscles. You see here the yellow circles invaded pectoral muscles as seen in the sagittal view, okay? And the axial view, the involvement. The importance of knowing the extent of involvement is that change the treatment. So here you can see abnormal enhancement in the pectoralis, both in the sagittal and in the axial view. And that demonstrate the involvement of the pectoralis muscles. And here, this is a T1 sequence, demonstrate what here, this is a mammography, and this is a clip. And this setting of images help to visualize the clip as a signal void. So it is essential to understand the use of each sequence on breast MRI. Okay. The standard MRM acquisition protocol should include at minimum T1 weighted pre and post contrast and T2. Okay? Talking about the T2, usually we call it the anatomical sequence, okay? And signal analysis. Usually demonstrate the normal anatomy like lymph node, vessels, fat, which are bright on T2, and bright parenchyma in a lactating woman. So also, several studies have reported that T2 imaging increases the specificity to differentiate benign from malignant, and the T2 fat suppressed enable to visualize the fluid in a cyst in a normal ducts and to visualize mucus and blood. T2 weighted images without fat allow better depiction of the morphology and the fat containing lesions. And T2 allow depiction of perifocal and peripectoral edema in breast, and most of the T2 bright lesions, most of which are benign, like cyst, apocrine metaplasia, myxoid fibroadenoma, fat necrosis, lymph nodes, and so forth. Cancer usually on T2 are relatively dark due to high cellularity. However, certain types of cancer appear brighter like mucinous, necrotic, metaplastic, and so forth. Okay. Regarding the basic of MRI breast for cancer detection is the T1 weighted pre and post contrast images. First of all, we have to take a native T1 weighted acquisition, okay, before contrast administration. Then that may be performed with or without fat sat. Can be fat sat or non-fat sat. Then contrast administered at a maximum 0.1 millimole per kg. Preferred automated injector at a flow rate of 2 ml per second rate, followed by flush of 20 ml of saline. It is essential to obtain an image approximately 60 to 90 seconds after contrast material administration. Why? Because this is the big enhancement time of breast cancer. Then T1 weighted acquisition is repeated for about 6 total, at least 3 times. The slide thickness should be no more than 2.5 millimeter. As we have mentioned, we need a high resolution. And with modern MRI units, a much higher resolution of about 1 millimeter and lower are easily obtainable. Allow for evaluation of contrast uptake and enhancement kinetic profile of lesions, and the images are usually acquired in the axial plane. Why? Because it is faster than the sagittal acquisition and it provides a better overview of bilateral breast. Bilateral dynamic axial 3D sequence for performing volume and multiplanar reconstruction. And as we have mentioned earlier in the previous image, this sequence can detect marker placed after biopsy as a signal void. Okay, let us take these examples. This is a pre-contrast scan, T1, and this is post-contrast, okay, T1. If you look here, definitely it is the lesion, it's more or less of similar intensity as the adjacent parenchyma, but in post-contrast, it becomes brighter than the adjacent parenchyma. Okay, this is example of fat T1 fat suppressed image, pre and post contrast. So it allows evaluation of contrast uptake enhancement. And why the contrast in this cancer visualized here so bright adjacent to the normal parenchyma? Because the underlying principle is that new angiogenesis in case of malignancy lead to the formation of leaky vessels that allow for faster extravasation of contrast agents, thus leading to rapid local enhancement. So the rapid local enhancement in cancer due to extravasation in a new angiogenesis. Again, this is a pre-contrast fat suppressed T1 and post-contrast in a case of fibroadenoma, which enhance, okay, intensely enhance compared to the adjacent parenchyma, but having the morphology, okay, of smooth outlines and oval shape. We are not going to discuss these abnormality, but as we have mentioned earlier, there is overlap between benign and malignancy, okay? But at the end, we are going to take it in more details in the coming lectures. But here, just we want to know how contrast image help us to detect a lesion in the breast. So lesion detection at contrast enhanced MRI is primarily based on a lesion vascularity relative to normal tissue. Initial enhancement is determined by comparing the first post-contrast images to pre-contrast images. So this might not be the first one. It can be second, third, or even fourth, okay? So unless comparing the first post contrast, we cannot say this is rapid enhancement. And as I mentioned, the morphology can help in differentiating. Okay, if we take this example here, this is the fat suppressed T1 pre-contrast, and this is fat suppressed T1 post-contrast. If you see here, not only the mass is intensely enhanced, okay, but also there is intense enhancement in the adjacent parenchyma in the segmental distribution if you compare it with the remain of the parenchyma. Why this parenchyma enhance intensely compared to the remain of the parenchyma? For the same reason as we have mentioned earlier, the new vascularity and extravasations, okay? This is because this parenchyma is a diseased parenchyma, is not a normal parenchyma. So it is rapidly enhancing compared to the normal parenchyma. Typically, cancer is typically enhanced more avid and more rapid than the surrounding parenchyma, as we have seen here in the mass as well as in the non-mass enhancement. And this is usually seen within the first 2 minutes after contrast injections. The mass taking up contrast significantly, and while the surrounding parenchyma is still not show enhancement. That is why that is the base or the principle for evaluating contrast enhanced MRI. Again, as we mentioned, that lesion detection at contrast enhanced MRI is primarily based on lesion vascularity relative to normal breast tissue. Okay, leave this extensively infiltrating left breast, but look for the normal breast. Look for this area is abnormally enhanced compared this edematous, okay, because this is not a simple edema. This is lymphangitic carcinomatosis edematous, okay, edema involves this part of the breast, so it significantly enhanced along with the adjacent pectoralis, involved pectoralis. You see, it is intensely enhanced compared to the adjacent fat here, or the breast parenchyma in the right side. Okay, since the main of the study usually has to detect breast cancer, despite improvement in techniques of breast MRI, contrast enhanced study is still the basis of breast MRI of all clinical practice or clinical protocols. So the base of breast MRI for cancer detection is contrast enhanced breast MRI. Okay, if we look for this example of cancer, this first post-contrast, and this is later sequence, post-contrast sequences. If we look here, definitely we can see intense enhancement in the first post-contrast image, which indicate rapid wash-in of the contrast. And because it is open, okay, the open capillary, okay, so this contrast rapidly move out, rapidly wash out from the lesion. So rapidly getting or washing, rapidly wash out. So this is how breast cancer behave. Most of breast cancer behave like that. Rapid wash in, rapid wash out. Okay? We can take this example. This is subtraction 1 minute. Okay? Look for this lesion. This 2 minutes. This is 6 minutes. If we compare this with that one, which one is more bright? This one, yes, the 6 minute enhancement is intensely brighter compared to the first minute. So this progressive enhancing features, this is the feature of benignity, okay? Not the feature of cancer. Cancer usually we can see the enhancement intense in the first minute and become less when we go up or when we see the coming repeated post-contrast study. Okay, so initial enhancement is determined by comparing the first post-contrast image, okay, to the pre-contrast. When we look for the first one, we can determine how intense is contrast wash in. Okay, then look for the remain series of the post-contrast to see how rapid wash out or how it progressively get in or wash in or progressively enhancement. These are two different features, discriminating benign from malignant. And because of that, okay, is the base, this is the base of breast MRI contrast enhancement consists of a dynamic study to discriminate. Both can take contrast, both can intensely enhance, but to discriminate between benign and malignancy, it looks how they behave. Both the benign and malignant behave differently in a dynamic series. That is why the breast MRI contrast study is a dynamic study. What is the difference between these two cases? This is same patient and this is same patient. Can you tell the difference? Any volunteer? Do you know the difference between the sequences? Is it pre-contrast or post-contrast?
It is in the first one, in the upper left.
Here?
This is T1 post-contrast without fat sat.
Excellent. Post-contrast without fat sat. Excellent. And this?
This is subtraction with fat contrast with contrast.
This is fat sat. Okay. Fat sat. Okay. And this one?
Fat sat with contrast.
What is the difference between these two? This is the same patient.
Both fat sat.
Why?
Subtraction.
Yes. Which one is subtraction?
The left one.
This one.
Excellent. Yes. Fat sat.
The left one.
And from the fat sat, subtractions performed. So in this here, we have T1 weighted images without fat sat, both contrast without fat sat. And this is both contrast with fat suppressions. So as we have mentioned earlier, T1 contrast enhanced image can be performed with or without fat suppression. You might see it with fat suppression, you might see it without fat suppression. Okay, regarding this example here, this is both contrast fat suppression, from which subtraction technique performed. So this subtracted images from this. Okay, so undertaking a native sequence with fat suppression here. Type. Okay, paired with subtraction improve the detection of lesion and analysis of contrast uptake when the subtraction are degraded by movement. It is, if we do both, it is helpful because sometimes subtracted, each one can overcome the limitation of the others. Okay, if the subtracted images affected by the patient movement, we already have the fat sat, we can depend on which. Okay, or if not enough fat saturation occur and there is artifact, the subtraction can help. And also doing both can help us to see if the bright signal in non-fat sat, okay, suppressed in the fat saturations images, it will signify that it is related to a fat containing lesions rather than an enhancement. This can also help us. Okay, if we look here, this is pre-contrast, there is no enhancement. Non-fat sat. This is both contrast non-fat sat 6 minutes. And I can see something here, okay, not seen here, but really difficult to tell if there is enhancement or not. But in subtraction image from this 6 minute, the 6 minute post contrast from subtracted from the pre-contrast, clearly define or appreciating the enhancing, small enhancing mass in these subtracted images. So breast has significant adipose tissue without fat suppressions. Okay, it looks very bright. It can be looks very bright. Okay, creates significant background. So fat suppression in post-contrast is really essential and important. For images obtained without fat suppression, creating subtraction from the pre and post-contrast acquisition is required. Because we cannot evaluate this post-contrast without doing these subtraction images. Why it is from the 6 post-contrast, not from the first one? What do you suggest? Why subtraction is performed from the 6 post-contrast?
To see if there is washout or not, or washing.
No. If the lesion intensely enhanced in the first image and disappear in the 6th image, then in the 6th post-contrast, then we will subtract from the first image. But if the enhancement seen in the delayed post-contrast images, that means this is a progressive type of enhancement. And usually we are looking for the intense contrast enhancement. So this obviously it is a progressive type of enhancement in a benign type of enhancement. Okay. Breast cancer are sensitive to contrast, enhancement regardless of tissue density. If we look for this breast here, this is the mammography. Look how it is dense. And look for the parenchyma here in the MRI, same parenchyma. But depend on what? On background enhancement. Here the background enhancement is not much. Okay? So if we have enhancing breast cancer as illustrated by this circle here, it will be obviously visualized regardless of the density seen neither on MRI nor on mammography. And even doing subtraction from this fat-SAT MRI, you see, make it more clear. Subtraction, so removal of breast tissue. When we do subtraction, this is 2D and these are 3D, either from 2D or from 3D. Okay, fat-SAT or not fat-SAT. When subtraction performed, that means it removes the parenchyma. If you compare the image here, look for the parenchyma enhancement. They remove the parenchyma. Look for the 3D. You can see the parenchyma in the 3D here, but you cannot see any parenchyma, background parenchyma in the subtraction images. So in subtraction images, usually parenchymal tissue subtracted, removed. So any abnormal enhancement in background will be even more obvious, more visualized. However, any technique has a limitation or has limitations, okay? If we look here, this is 3D fat suppression, but any motion artifact, chemical shift artifact, or poor fat suppression can result in lack of homogeneous fat suppression, especially in the 3D. Because in the 3D, it will give you the global appearance, okay? The non-fat SAT might be at the bottom of the breast. If you go for the axial images, 2D axial images, you might not see throughout all the images. You will see it at the bottom of the breast, maybe, or at some of the sequences, some of the images, I mean, axial images, okay? But when you do you perform the post-processing 3D MIP scan, it will appear like that, because it will give overview for the whole breast as a whole. Okay, and it might obscure, either might obscure underlying abnormal or might mimic an abnormal. Definitely here it is bilateral global. Most obviously this is artifactual. But if there is any background or underlying abnormal enhancement, it is difficult to be like here. And in this, I might say this is an abnormal enhancement because it is a focal area. So this is one of the drawback, and it can give false positive or false negative impression. Okay, regarding the subtraction images, also has the limitations. Okay, as we have mentioned earlier, we said that if the patient move, we need to put the patient more comfort. Okay, so as not to move during the study. If the patient move after taking between the images, between pre and post contrast, there is movement. When you do subtraction of post contrast from pre-contrast image, then it can give misregistration artifacts. Okay. If we look here, this is a subtracted images. It gives impression here there is abnormal enhancement, non-mass enhancement, but it was not seen in the native images following post-contrast enhancement here. But not that, not only that, if you look here, you can see abnormal enhancement of the pectoralis muscles. So all this due to motion artifact give misregistration artifact. So what is the lesson from here? What is the teaching point? The teaching point, we have to read both the native image and subtracted image. And especially if we suspect any artifact, we have to make sure and correlate the subtracted images with the native post-contrast images. Okay, so breast MRI has evolved from primary contrast enhanced technique to a multi-parametric techniques in which T2 and diffusion weighted images are routinely performed. Okay, we can take here example for T2 as we have discussed it early in this lecture. We said that T2 is part of the standard MRI protocol, and we said it can be performed with FAT-SAT or without FAT-SAT. And in both here, we can see very bright cyst, okay, water content cyst. But if you compare the FAT-SAT with non-FAT-SAT, how about the margin of the cyst? How about the morphology? We said that the non-FAT-SAT always help us, okay, in depiction of lesion morphology much better than in FAT-SAT. Okay. Most, as we mentioned, most of the masses appear as pride on T2 are benign, like cyst, okay? Myxoid fibroadenoma, fat necrosis, lymph nodes. So here we can see examples. This is axial, okay? Axial T2 suppressed and non-suppressed. And here T2, no, this is T1, sorry. This is a T1. And here we can see Sagittal T2 demonstrate multiple cysts. And what about this? This image here.
Sagittal
Huh?
T2 fat sat with contrast.
Excellent.
Sagittal T2 fat sat with
These are
contrast.
post-contrast. To detect the post-contrast, look for the heart. You see, when you see the pride, that the contrast inside the heart, so it will help us to determine the post-contrast study from other studies. So this is a cyst here. The biggest one here demonstrate minimal peripheral enhancement or wall enhancement, reflecting inflammatory nature. It's okay. Okay, this is, as we mentioned earlier, we said that T2 detect lymph node as high signal intensity, intermediate to high signal intensity. Okay? These are normal lymph node, and this is a metastatic lymph node. Also appear as relatively bright on T2. It's okay. If we look for this here, this example, this is T2, non-fat SAT, and this is fat SAT. This is fat SAT. Look for the full ultrasound, how it is ugly. So these lesions contain tiny cysts, part of which cyst, and this is suppressed area corresponding to high signal intensity in non-fat SAT. In a case of fat necrosis, look for the lesions, how it was suspicious on ultrasound. That is my patient, you see? From MRI, we can clarify that the lesion was a fat necrosis, not cancer. Okay, this is example of a fibroadenoma. Look how it looks bright. Okay, this is post-contrast, intensely enhanced, and here T2 fat SAT and T2 non-fat SAT. Even here, it looks bright. So, as we mentioned earlier, myxoid or myxomatous fibroadenoma appear bright on T2. Generally, as we mentioned, cancer doesn't look bright on T2 because of high cellularity. It can be intermediate to low in general, okay? And this example here, how it looks dark on T2 and intensely enhanced on both contrast images, this irregular mass in the case of invasive breast cancer. And another example here demonstrate what? Intermediate signal intensity on T2. However, the area of necrosis appear as bright on T2. As we mentioned earlier, necrotic cancer appear high on T2, and corresponding post-contrast study, the necrotic area does not take contrast in this image here. You see, this is a necrotic area, the viable tumor tissue taking the contrast, while the central necrotic area doesn't take the contrast in a case of invasive cancer, proven to be invasive cancer. But from images here, it is a BRAT5. It's obviously highly suggestive of malignancy. That was from literature. But this is my patient. This case is my patient. And now we are studying T2. Look for the T2 here in this image. And look for the post-contrast, the lesion here. It appears as very bright, and this all extensive edema surrounding the lesions. As we mentioned that there are certain type of breast cancer appear as bright on T2 like mucinous, medullary, metaplastic, necrotic. Okay. Here we can see breast edema, bright on T2. Here breast edema, this is the same patient, edema. You see, very focal or lesion edema and pre-pectoral edema. And the pre-pectoral edema is almost always suspicious. Whenever you see a pre-pectoral edema, it raises a level of the level of suspicion to a higher level. You see, it is a suspicious, the pre-pectoral edema. T2 demonstrate the pre-pectoral edema and the perilesion edema. And here you see extensively edematous enlarged left breast, and the edema extend across the midline to the contralateral breast. This is the abnormal behavior of Sudanese ladies. Okay, and what about this parenchyma here? Sorry. What about this parenchyma? It looks also a little bit edematous in a case of fibrocystic. Do you remember the secretory phase? We discussed in ultrasound images, and we said that it is not suitable to do ultrasound, MRI, or mammography in the second half of the cycle because everything is proliferating. We have cellular proliferation, inflammations, and edema, okay? Throughout the normal parenchyma, there is proliferations, there is fluid retention, and all these changes can be exaggerated in a case of fibrocystic and give a high T2 parenchyma of a fibrocystic breast. Okay, this is the same patient I have shown to you in the above examples with edema. You see, edema, and this is the post-contrast image, okay? And we mentioned that the literature say the cancer seen as high T2 could be mucinous, necrotic, or metaplastic, okay? These are certain type, or sometimes the cystic component of papillary, for example, if the nodule is small and the whole lesion is cystic, can appear as bright. But these are two examples from my practice, both of which demonstrate high T2 lesions. Look for the lesion, this is T2, and this is the lesion on T2. Both are very high or very bright on T2, and these both contrast, and both of which were proven to be invasive ductal carcinoma. So we have to be aware about this issue. It doesn't mean being so bright on T2 that exclude to be a breast cancer. Okay. Multi-parametric breast MRI protocol can be adapted to the clinical indications, and additional sequences depending on the indication, patient history, and institutional protocols may include. These can be include T1 non-fat SAT. If you look here, this is a large lesions, and here this is T2 and fat SAT, and this is post-contrast fat SAT. Demonstrate a fat containing lesion in a case of pseudoangiomatous stromal hyperplasia. So we benefit from T1 pre-contrast. T1, I mean T1 non-fat SAT, here non-contrast, giving us or showing the fat content of that lesions. So also can be helpful in a case of fat necrosis, in blood product, and in architectural distortion. This is a case from literature. But this is my patients. These examples of a case of hamartoma, having bilateral hamartoma. You see, this is the non-fat SAT T1. Okay, can you see here the right hamartoma? The left one is not seen in this image. The level of the two lesions is different. But if you can see here, you see, this area are subtracted. These are fat, while the glandular component here demonstrate intense enhancement in both contrast. And this is diffusion weighted images, okay? No, sorry, this is T2. Excuse me, sorry for confusion. This is T2 of the same lesions. You see, this is the lesion appear bright on T2, okay? And the fat suppressed here on T2, and the left lesions here appear of intermediate to a darker signal intensity, and I will show you why. It looks like that. Here, this is the same patient, okay? This is diffusion weighted images, okay? Diffusion weighted images also considered as the component of the protocol, okay? Is one of the technique used in the breast cancer protocol. I'll talk about the patient, then we'll go to talk about the diffusion, because this is the same patients I have told you about. And in diffusion, both lesions appear as high signal intensity. But when we go to the ADC map, on the ADC map, the right one doesn't show change in signal or loss of signal, while the left one, this one, demonstrate what? Decreased signal intensity consistent with restricted diffusion. So both are bilateral hamartoma. This lady, she has bilateral hamartoma, hamartomas for about 16 or 18 years, okay? And presented to us in the year 2014, okay? With a progressive enlargement in the left side hamartoma. And our images demonstrate this suspicious feature and proven to be a cancer arise in a hamartoma. And at that time, it was the case number 14 in the literature. There were 13 reported cases of a breast cancer arising in a hamartoma, okay? Okay, this is regarding the case. So this is restricted diffusion. What is diffusion images? What is diffusion technique? Diffusion is a functional method. Depend on what or based on what? Based on quantifications of motion of water molecule in a tissues. Okay? And this movement influenced by the tissue microstructures and cell density. Whenever the tissue having higher cellularity, it will restrict this movement, okay? And this random motion of water molecule can assist in characterization of the lesions. And as you know, the cancers usually highly cellular, you see, and tightly packed cells, so it prevents these motions and lead to higher signal intensity at diffusion weighted images. Okay? While the ADC represent what? It is a quantitative measurement to estimate the degree of diffusion of this movement from the diffusion weighted images. Okay? And because so the more hinder the motion, okay, the more restrictions of the motions within the cancer lesion or cancer tissue, it will result in lower ADC. We said the motions, the ADC is a measurement, quantitative measurement of these motions. The more motions, the higher the ADC. Okay, so if the lesion is fluidy, it will appear brighter in the ADC, the high ADC number. But if there is compact cells preventing the water, the particle or molecule movement, so when I quantify this movement, it will be low. So that means the ADC will be low. And when we say low ADC, we are talking about restriction. Okay, this is what does it mean? Restricted diffusion weighted images. So because the range of the ADC in a cancer is about 0.8 to 1.3 times 10 to cubic millimeter square per second, while the range in a benign tissue is higher, is from 1.2 to 2 times 10 and so forth. Okay, so consequently, cancer having low signal intensity on ADC. And the ADC measurement did vary depending on B value. Okay, so usually on diffusion weighted images, we used a B value of 0 and other higher one. And it is recommended to have, okay, to have B value of 0 and 100 and 800 second per cubic per square millimeter. Why recommended this? Because they have mentioned that the B value of less, the diffusion performed using B value less than 1,000 shows the greatest accuracy in distinguishing benign from malignant. And there are many other reasons for that. So at the end, we need certain parameters and certain situations, okay, to do this and to get to reduce the signal to noise ratio and to improve the quality of the diffusion. But this is general concepts, okay? Is that clear? Shall I go to the next? Okay, so if you look for this, if you look for this example here, we have high signal on diffusion weighted images, and the ADC map demonstrate low signal intensity compared to the parenchyma, very low. Okay, so what does it mean? It means restricted diffusion. So diffusion weighted images optimize the characterization of lesion, differentiate between benign and malignant, and improve detection of small lesions. If you look here, posterior to this lesion, we can see something here. This is the chest wall, and this is the vessels. This is the internal mammary vein. Within this internal mammary vein, we can see focal enlargement, and this is contrast enhancement. The lesion enhance and the vessel enhance, but the ADC map, sorry, in post contrast it enhance, and in diffusion here it appear bright, and the vessel is bright, but the ADC map help us to show a low signal intensity signify restricted diffusion in a case of malignant thrombus. So this is a malignant thrombus from these lesions entering the internal mammary vessels. Okay, this is my patients or our patient. One thing, whenever we see a breast cancer, we have to remember heterogeneity. Okay? If you look even for the ADC here, very dark, while the central is still bright. Why it is bright? Because there is a central necrosis. So if we have a necrotic lesion, if the whole lesion is necrotic, it will appear as high signal on the ADC map, and this can be a false negative value. Okay, here we have another example of diffusion weighted images. This is example of fibroadenoma, and this example of invasive carcinoma. What is the difference? Here I can see intensely enhanced lesions. Bright on diffusion weighted images. Dark on the ADC map, going with restricted diffusion. This oval, enhanced, simulate that one. But being restricted in diffusion make it suspicious, and it was proven to be invasive cancer. As we have mentioned earlier, malignant tumor have high cellularity that exhibit restricted diffusion. But the morphology, more or less the same as this fibroadenoma. Oval lesion, both are oval, smooth. So using diffusion here, differentiate between the two. Let us see the other example. Here I have two adjacent fibroadenoma, enhanced on post-contrast, bright on diffusion, and even bright on ADC map. So reflecting what? Absence of water diffusion restriction. Did not restricted on diffusion. So here diffusion help us to differentiate between these morphologically similar lesions. Okay? So diffusion weighted images considered as adjunct to conventional breast MRI demonstrate high sensitivity and specificity in differentiating benign from malignant with a diagnostic accuracy of 91%. This is a restricted diffusion in a case of metastatic lymph node. This is the ADC map, bright on diffusion weighted, enhanced on post contrast, bright on diffusion, and restricted. Demonstrate this blue color, and ADC map with the ADC number of 0.6. So it is low, 0.6. Okay, so it's significantly restricted. Even the range of restrictions can be mild, moderate, or marked restrictions. Okay. Let us go for post-processing technique. All the above discussed techniques were acquisition technique. But as we mentioned, we have also post-processing technique. May generate additional data. These include maximum intensity projections. Here we have 4 examples of maximum intensity projections aiding in the evaluation of background parenchymal enhancement. It will give overview to the whole breast, demonstrating the background parenchymal enhancement ranging from minimal to mark. Okay. Again, example of maximum intensity projections, okay, demonstrating and helping us to detect small enhancing lesions. Very clear, can depict and show that any small enhancement, okay, and its relations. If you look here, you can see this in the posterior breast. It is a little bit away from the chest wall and pectoralis muscles and its relation to the adjacent vessels. Okay, so there is no involvement of these structures. Again, post maximum intensity projections. 3 examples. Here, I cannot see any abnormal enhancement or evidence of breast cancers. Literature case. Another literature case demonstrates this large infiltrating cancer and its extent, as well as the ipsilateral metastatic adenopathy. This is my patients, okay? Can you see, not only visualize this, the index cancer, but also we can see the extent of the disease and these small enhancement in a regional distributions, okay? In a segmental distribution, sorry, in a segmental distribution. So it aids rapid evaluation of disease extent, and breast MRI should depict all enhancing cancer 5 millimeter or larger in size. So down to 5 millimeter enhancing cancer can be detected by breast MRI, as you have seen here. These all are very small foci of malignancy. And in this example, we can see the MIP in 3 different planes: sagittal, axial, and coronal. So we can process it even in multiplanar reconstructions, okay? And this can help us also to visualize the extent of the disease, and if any abnormal or suspicious enhancement can be easily detected, and how it extends within the breast, and if it involves any adjacent structures, nipple, skin, chest wall, or vessels. And this is example from a literature of PASH, demonstrate enhancing mass. You see, can you see the shape of the mass in this multiplanar reconstruction of MIP? Look for the lesion here, coronal and axial, sagittal, coronal, and axial. It looks different, and its extents or lengths or dimensions of the lesions differ from the different planes. So the multiplanar reconstructions can be performed from MIP, or can be even performed from the axial image, okay? And here we can see this extent of, here number A, this is subtraction, early dynamic. And this is axial MIP and sagittal MIP from that lesion demonstrate extension. Can you see the extension of this lesion in the 2D and in the 3D MIP here? How does it look? Okay, so reconstruction in any plane is particularly useful. It facilitates the evaluation of lesion, especially the distributions of non-mass like lesions, and so also better localizations of any lesions or abnormal enhancement. This is the same patient. We have seen it in T2 and in diffusion and ADC map, the bilateral breast hamartoma. Here you can see the post-contrast image, okay? And this is the MIP of the same patients. This, here we can see the right one. This is the right, okay, hamartoma, which doesn't show any suspicious features, while the left hamartoma that rapidly enlarging demonstrate restricted diffusion, abnormal shape, and even the curve was suspicious, and it was biopsy proven that invasive cancer is present. And this is the right hamartoma, okay, which is a benign lesion, and this is the time intensity curve. So apart from MIP, we can also have the time intensity curve in post-processing technique, okay? That might add additional information. And this, which type of this time intensity curve is a progressive, persistent type 1, okay? Indicate benignity. And usually manually we draw a region of interest, okay? As you have seen here, the region of interest in the lesions, and then the computer will read and will give this type of curves. So the time course enhancement or kinetics type, there is overlap between benign and malignancy, but in general, okay, the slow persistent curve considered to be benign because the majority of this curve seen with benignity, while the rapid plateau curve considered to be suspicious. And if you look here, this is a benign tissue, while this corresponding to this plateau curve is speculated intensely enhancing mass, which is invasive cancer. And it's important point, we have to mention that we have to take multiple region of interest from the same lesions. Can you see here how many curves? They have taken 3 for each, okay? And you have seen this, I have shown to you this case in T2 earlier, and we discussed the central necrosis seen as bright on T2 and corresponding enhancement at the periphery, and the central necrosis does not enhance. The curve of which, can you see it here, how it is steep and rapid wash in and rapid wash out, rapid wash in, rapid wash out, and this is type 3 curve, rapid slope up and rapid wash out curve. This is, we call it a washout curve, and the type 3 curve. Here we can see the 3 type of curve. This is the more reflection of benignity, type 1 curve, and this is type 2, the plateau curve is suspicious, and this is the washout curve, more in favor of malignancy. Post-processing technique may generate additional data and also can include what is called color map overlaps of the enhancement curve distribution. This is our patients. Do you remember it? Having the invasive ductal carcinoma with DCIS, okay? Or DCIS with invasive ductal carcinoma appear as bright and intensely enhanced. If you look here in the color map, this reflects the enhancement kinetic, okay? This is a color map demonstrates the enhancement kinetic. And here we can see corresponding area of enhancement, a large enhancing area. And the CAT helps us to detect small red foci. What does indicate the red foci? Indicate what did indicate the or do indicate the red foci? Indicate that the washout curve type 3. The red in this color map indicate type 3 curve, intense rapid enhancement with washout. And if you look here, you can see multiple color. What does it indicate? Indicate heterogeneity. And as we mentioned, whenever we see breast cancer in any of the images, okay, we can see the heterogeneity. Can you see the heterogeneity in this kinetic image? Okay. This lesion demonstrates how many colors, all types of curves are present here. The washout, the plateau, and the type 1 persistent curve. Within the same lesions, you can see the 3 types of the curve. How the color map help us? It will pick up the red area. So we are going to put region of interest in this red color to show the washout. Otherwise, you might draw your region of interest in this, and it will demonstrate type 1 curve, and we'll say that these lesions demonstrate type 1 benign curve. Okay, computer-aided detection program. Again, this is enhancing lesions with washout curve, and computer-detected color map demonstrate this. You see, majority of lesion here, and mainly at the center is red. You see, that is why it's immediately corresponding to this is the region of interest at the center, corresponding to this red area showing the washout curve. Okay, so computer-aided detection program is purely kinetic evaluation. It has no role with anatomy or pathology. Nothing with morphological criteria. It is purely kinetic evaluation. It saves post-processing time. It can do multiplanar reconstruction very well and very quickly. It also has some very nice features that can correct the motion registration subtraction artifact. You see, it will eliminate the misregistration artifact of the subtractions, and it can improve accuracy of breast MRI. It reduces the false impression diagnosis, okay? And it promotes reproducibility, consistency, and accuracy. So it's really helpful. But not all breast MRI scanners can do this computer-aided detection program. In CAD, as we mentioned earlier, red is bad. it means type 3 washout curve, probability of cancer is high. Okay. Magnetic resonance spectroscopy. What is the spectroscopy? Spectroscopy is a proton magnetic resonance spectroscopy provide the proton magnetic resonance spectroscopy provide biochemical information about the tissue under the investigation, and it determines the choline level that reflects cellular proliferation associated with malignancy. This is the choline level here at resonance 3.2. See, we are going from here to here. 2, 3, 4. So here 3.2. At 3.2, we will see the choline resonance. And what does it indicate? Not indicate presence of cancer, but indicate presence of active cancer. And this has a significance. Active cancer. Okay? And as you know, it performs in the brain and in other tissue, but it performs spectroscopy in breast a bit delay, okay, because of heterogeneity or heterogeneous distribution of glandular and adipose tissue make it difficult. Again, the heterogeneity and the breast. You see, it makes it difficult. And spectroscopy may decrease the number of benign biopsy recommended based on MRI findings and may help predict response as early as 24 hours after the first dose of neoadjuvant chemotherapy. It's really helpful in the evaluation of chemotherapy treatment. See, they found that it can predict the response for the chemotherapy treatment after 24 hours. They are doing a baseline, okay? And after 24 hours after 24 hours from taking chemotherapy, another MRS, and after the 4th dose. And it can show the clue of response to the chemotherapy. Usually perform on 1.5 Tesla or greater. It needs high field, okay, needed for MRS. And it is an acquisition, okay, pulse sequence. It requires contrast study for localization, okay. Large amount of breast fat result in mobile lipid, give some artifacts and obscure detection of choline peak. There are 2 types, okay, of techniques: single voxels and multi-voxels. The monovoxels acquisition has a predominantly been performed, but of limited value, 1 lesion at a time, okay? And acquisition time about 3 to 12 minutes, 10 minutes more for pre-acquisition preparation, setting up. And multivoxels sequence are the preferred technique for multiple lesions. Can be used to measure multi-regional metabolites. Okay, here we can see examples. This is a lipid, but here there is no choline peak. The choline is flat. There is lack of choline peak. Why? Corresponding to normal parenchyma. Okay, the normal parenchyma. While in this case, so this is normal, but true negative. But this is here, this is lobular carcinoma. Look for the choline elevated. So with SNR greater than 2 at 3.2 resonance. So it is true positive in this case. This is true negative. This lesion not considered to be malignant in a case of fibroadenomatoid. There was no choline peak, okay, and the biopsy demonstrated benign lesions. While in this, here, you see, this is a patient lumpectomy, and there is a clump ductal enhancement, but the MRS demonstrate no choline resonance and biopsy proven fibrocystic changes with hyperplasia. And this example here, you see, this is suspicious lesions, okay? And there is no choline present, but the biopsy proven to be invasive cancer. So, like any other techniques, we might have a false negative and false positive even. In this case, here suspicious, demonstrate choline, biopsy proven atypical chronic inflammations. Okay. What is abbreviated breast MRI? Abbreviated breast MRI is a limited MRI technique used for screening MRI. Okay, what do we do? Only two sequence. T1 single T1 pre-contrast and single T1 post-contrast. That is all, okay? The study can be obtained in less than 10 to 15 minutes, but it still yields high sensitivity for detecting breast cancer. Why? As we mentioned earlier, breast cancer usually enhance within the first 2 minutes. So in the first post-contrast, breast cancer will intensely enhance. So for detections, for cancer detections, it is more or less enough to detect or to exclude cancer. If there is no enhancement, that means there is no breast cancer in the majority, not 100%, but in the majority, there is no breast cancer. It has diagnostic accuracy comparable to that of conventional full MRI protocol, but this is usually performed just for screening to say there is something or there is no suspicious findings. A single MIP image post-processing and subtraction can be performed. Okay, interpreted the image by first looking at the MIP to assess for any mark enhancement. Okay, so this is reducing the time and cost of breast MRI increasing, and consequently can improve the access to MRI screening to a wider populations, providing superior sensitivity for early detection than either ultrasound or tomosynthesis. Okay? Okay. Ultra fast. What is ultra fast? As simple as that. You know that cancer taking enhancement so rapid, while benign lesion a little bit delayed. Okay, late. So we need we need MRI machines, okay, having capability to pick the cancer or to pick this enhancement as fast as possible. As fast as possible, okay? And most breast cancer start to enhance within 10 seconds after arrival of contrast in the major vessels, whereas benign lesions on average later enhance by more than 15 seconds. Okay, if you look for the curve here of cancer, compare it with the benign one. Okay, here we can see this example. This is invasive cancer. okay? And this is fibroadenoma. This is the care for the cancer, and this is the care for the adenoma. The cancer, if we look here for the time, this is the aorta, enhancement of the aorta. The invasive cancer only 8 seconds after the contrast seen in the aorta get enhanced, or it show early enhancement after 8 seconds only. Okay, so it's so rapid and steep slow, rapid, steep, slow. You see, this is the invasive cancer. While the fibroadenoma, okay, taking the contrast after 17 seconds, take the contrast 17 seconds after the aorta. Here, look, this start early. The cancer, only 8 seconds, while the fibroadenoma, 17 seconds. Okay, so, and even look how it is steep, and this is just a moderate enhancement. And there are certain techniques and certain machines and high field 3 Tesla and a lot of parameters, and these things we can discuss it later in advanced technology, just to have idea and to be aware about this technique. Okay, MRD. What is MRD and MRM? You know MRM. We said MRM is MR mammography. That means it is MRI of the breast. But what is MRD? MRD is MR ductography. MR ductography. Okay, it is a T2 sequence, a special T2 sequence performed with certain parameters to enhance the ducts. If you look here, we have conventional ductography demonstrated regular ducts with filling defects. This is MR ductography, demonstrate a dilated ducts with signal defect within the duct. MRM, MIP, demonstrate hyper signal intensity lesion within the nipple. Does it correspond to the signal defect here? Maybe. We can see it in the fusion image. What is the fusion image? They fuse the MRM with MR ductography. And in both here, we can see the dilated duct, and the arrow pointed to this intraductal lesion seen on MRM. This is enhancement. The MRM, MIP, the MIP is enhancing lesions. So this enhancing lesion was corresponding to this filling signal defect within the duct, and it's seen here. This is corresponding to the intraductal lesion and the ductal ductectasia. Again, this is same conventional ductography, demonstrate abnormal ductal system, irregular and interrupted, scattered throughout large area of the breast. And this is the MR ductography, demonstrate these are the abnormal ductal system. Okay, and cystic dilatation of these ducts, also it with some nodules and interruptions. And look for the MIP, demonstrate abnormal non-mass enhancement in large area in a case of invasive cancer. And this is the fusion images, demonstrate the ductal system and its interruption by this huge malignancy. Okay, this is image. If you look here, this is HER2, luminal A, triple negative, luminal B. What does it mean? It means that to evaluate the dynamic contrast enhancement magnetic resonance kinetic characteristic of breast molecular subtype. They are using certain parameters, okay, post-processing and this issue, and they assess the molecular subtypes of the breast. We are going to discuss it in more detail in the advanced technology of the breast, and here of MRI breast. Another recent technical advances include perfusion map. It is obvious here. We can see colored around the mass, and we can see the high amplitude in the curve. It means that high perfusion. If we look here, the curve become flattened. That means complete regressions and no more colored lesions seen here. And this is post-chemotherapy trial. This also technique helpful to demonstrate the treatment response. It's used for prediction of the treatment response. Okay. Okay. So to summarize, in general and in most clinical practice, the protocols begin with non-contrast enhanced acquisitions, T2, and then diffusion before taking the contrast, then followed by T2, followed by T1 pre-contrast and subsequently T1 post-contrast image. This is the basic protocols of breast MRI in most clinical practice. T1 diffusion pre-contrast, then take T1 pre-contrast and proceed with post-contrast. That is the basic. The others are additional. Okay, what is the sequence of this MRM image?
T2.
T2.
Complete.
T2 without fat sat.
Non-fat sat T2 or T2 without fat sat. Demonstrate what?
Fibrocystic changes.
Multiple bilateral cysts.
Excellent, well done. And here with fluid debris level. Okay, whenever you see a non-fat sat T2 lesion brighter than fat, that means it is a cyst, okay? And what are the MRI sequences here?
This is
T1 post-contrast
T1 post-contrast fat
with
sat.
fat sat.
All? What is the difference between these images?
التايم.
What?
Timing.
Timing, excellent. Timing. All are post-contrast, but the difference, why different in timings? Look for the contrast,
only.
contrast in SBC. Minimal contrast here in the right heart, while in this one, the whole heart, okay? There is intense contrast throughout the heart, okay? So that is the difference. And what is the difference here?
يا بص في الصورة الأولى
Yes.
لو سمحت
ها.
في أول صورة كان فيها multiple cystic lesions in both breasts.
This one?
The breast on the left side السيست اللي قلنا فيها debris.
Yes.
هل هو ده artifact يا بص ولا debris؟ يعني عشان البيشنت بتكون برون.
No. So
أنا
sometimes
افتكرت إنه الدبرس المفروض يكون على جهة النيبل.
I understand what you have said. You can say fluid level. Sometimes the debris it contain fat.
Oh, okay.
Okay, the fluid it is not
So it will be
always.
higher.
Yes, it can be lipoprotein, it can be fat, so it can be floating.
Mhm.
Okay.
Okay.
That
Okay.
means it is not a pure fluid. This is not a pure
Mhm.
fluid. This is fluid, okay, and this is something non-fluid.
Okay. شكرا.
Mixed, okay, mixtures, but it might be mixture of lipoproteins, okay. What is Abir? What is the difference between these two images? The sequence, regarding the
Okay,
sequence.
Okay. The image on the left side.
This one?
Yeah. No. On
This?
with L marker. Yeah. This is T1 post contrast non-fat sat.
X non-fat sat? Why?
The other one on the right, yeah.
Why non-fat sat? Where is the fat? Can you see fat here? White is black. The other is?
Okay.
You get confused.
Also T1 post contrast fat sat. So this is subtraction image. The first one is fat sat.
This is T2 fat sat, and this is post contrast fat sat. Okay?
Okay.
This is not subtraction image.
No, it is T2. What are the MRI sequence here?
T2 fat sat.
Silicon suppression.
Excellent, well done. So here we are dealing with silicon specific sequences. And the protocol may be adjusted for breast implant using silicon specific sequences to assess silicon integrity. And we will discuss it later with implant, okay, or with breast augmentations. Okay, in conclusion, multiparametric assessment of breast lesions allow for excellent discrimination between benign and malignant lesions. For lesion detections, the acquisition of two T1 acquisition at a specific time point when pre-contrast and approximately 90 seconds single post-contrast is usually sufficient for lesion detection, sufficient, okay? All other sequences improve the differentiation of breast lesion to prevent false positive and false negative classifications. The standard breast MRI acquisition technique include T2 weighted images that depicts fluid mucus edema hemorrhage and multi-phase T1 fat suppressed pre and post contrast sequences. Most high T2 sequences are benign. However, some rare malignancies appear to be bright. So radiologists need to be familiar with the appearance and characteristic of T2 breast lesions. Additional sequences and post-processing technique can be added to improve breast specificity and diminish unnecessarily biopsy or aggressive management. Non-fat SAT T1 sequences for distinguishing fat-containing lesions such as fat necrosis, blood product and architectural distortion. The potential applications of diffusion-weighted images include lesion detection, lesion characterization, and assessment of treatment response. And the positive predictive value of the addition of diffusion-weighted images for detection of malignant breast lesions improve the diffusion-weighted images improves the positive predictive value of MRI for detection of breast lesions or breast cancer, and plays important role in post-operative evaluation, improved detection of early recurrence, as well as evaluation of chemotherapy response. The two potential clinical applications of MRS are as an adjunct to breast MRI to improve specificity in differentiating benign from malignant, and here MRI improves the positive predictive value of biopsy from 35 to 82% and avoid biopsy in 57% of lesions, okay? And without any cancer going unrecognized. And the second is for monitoring or even predicting response to chemotherapy treatment, okay? Identifying resistance to standard chemotherapy. The post-processing technique include maximum intensity projection, MIP, color map overlays of the kinetic, and the time intensity curve. Thank you very much for your patience and attention. And sorry for taking you too long. I hope you could benefit from this discussion. And if you have questions or comment or any suggestion, you are welcome. You can open your mic and start discussion if you like. Do you have any question?
Yes, I have a question.
You are welcome. Start.
بالنسبة الهامرتوما, what are the changes إنه في يعني cancerous changes, الحاجات اللي نشوفها الMRI?
On MRI, okay.
Yes.
Okay. From the start, regarding this case, okay, it was suspicious. The first suspicion is after 16 years, suddenly both bilateral benign lesions were stable. Suddenly one of those lesions start to increase in size and get a little bit painful, mild pain. Okay, this is one suspicious clinically. Okay, ultrasound features was different. There was suspicious abnormality within the lesions. Okay, and then on MRI, unfortunately, I've lost the other sequences. Okay, but the lesion, as I showed you, the lesion on T2, okay, or I have one image from the case, T2 images demonstrate that the hamartoma of the right side was typical hamartoma containing fat, which was suppressed on T2, and the other part, it was bright, very bright, okay? While the hamartoma on the left side contain large area of intermediate to low signal intensity, which is suspicious, corresponding to signal intensity of malignancy in general. and demonstrate restricted diffusion. And the curve, it was suspicious. Okay, type, I think it was type 3. While the hamartoma on the right, the curve was type 1 curve, the hamartoma on the left giving type 3 curves. And the biopsy was proven to be invasive cancer.
تمام يعطيك العافية يا بس.
ويعافيك. Thank you.
شكرا يا
Any more
الله
suggestions?
يسعدك.
You are welcome. Who's talking?
أنا سارة.
Sarah Almat?
أيوة
Are you
مبسوطة
satisfied?
طبعا اليوم.
Are you happy now?
دبل تريبل هابي.
Oh, I'm so happy for your happiness.
الحمد لله. الله يذكرك.
Alhamdulillah. Alhamdulillah. Do you
I'm
have any
just
question? Any part not clear?
No, but it's still in the image. يعني I think T1 and T2 it is difficult to be differentiated. في أي حاجة بقدر أفرقها بينهم أول ما أشوفهم كده. Especially لو
Generally,
كان normal.
the parenchyma, يعني in general, the parenchyma on T1 darker than on T2 in general. Okay, and sometimes you might see the spine. Okay, and the CSF. If you are lucky to see the spine, the CSF, if you have seen it black, that means it is T2, T1. If it is bright,
Okay.
it is T2. It is T2. But sometimes if it is non-fat sad, generally, yeah, sometimes it's difficult to differentiate between the two. But generally, also the fat itself, I think, it appears a little bit more brighter on T1 than on T2. But it's not very clear. But if you start working and looking for as routine every day, when you look at it, you can differentiate. This is, yes, most likely. And at the parenchyma itself on T2, it is more iso to the muscles. But on T1, a little bit hypo than the muscles itself. I think during the practice, and I can search more, okay, when we are going to talk next time about the normal, okay, normal breast appearance on MRI, we are going to discuss about the sequences more. We'll dig on this more, and I will try to search for these subtle differences. I'll show it to you.
Okay.